why is it so tough to be a dentist? So can I ask, how many people are actually practicing dentists, or already practicing, making money from dentistry? Keep your hands up. Keep your hands up. All right. Well, you see, because I think it's so tough to be a dentist because we just have too many choices. And for those of you sitting in the room today, you've heard so many different approaches to these problems that you go back to your practice and like, well, which one do I choose? And these choices are tough. And then you've got these sales reps that knock on your door and say, mine is better than his. And these are just really, really tough decisions. And I've been practicing for 18 years, and I've made 18 years of mistakes. I didn't get here easy. I was kicked and pushed, and plus we have a tough job, and patients are difficult, and almost everything we do can fail. And I'm really glad that the previous lecture was about these complications, because everybody sets out to have success, but then we get these complications. And I'm an avid supporter of ethical dentistry, responsible dentistry, and I like to call this life-changing dentistry. And I want to include this message in everything that I talk about in the next 30 minutes. Because everything that you get to do changes a person's life for the better or for the worst. And the only person that gets to decide that is you. Is you. Let that sink in. There's no dental police. There's nobody looking over your shoulder. Only your personal moral ethics decide if you're going to have success or not. So just let that sink in. So implant rehabilitation started in '65 with Professor Brannemark and this quintessential implant. I placed my first Mach 3 external hex polished implant in 2000, and here we have a follow-up in 2015, and we have very little or no bone loss. And as well, we're not just about placing implants, we're about saving teeth. Now, one thing that's important to know is in Portugal, where I trained, we're licensed to pretty much do everything. So when you graduate, same as in Spain and in Italy, we get to do pretty much everything. So I'm the implant, I place the implants, and I do the restorative work as well, and I do the bone regeneration. And I'll talk to you a little bit today about how our team works. I've had an endodontist on my team for 14 years, and an orthodontist on my team for 14 years, and that's why we get to do these amazing cases. But back in the 70s, let's face it, the only real stress was, do these things work? Do they integrate? Nowadays, we got all the stuff that we've been listening to for the past few days. Immediate placement delayed, the implant surfaces, the importance of keratinized soft tissue. Everybody saw Howie's lecture yesterday. That's mind-blowing stuff. You know, I mean, Howie, I'm going to have to come to South Africa and learn with you some more, man, because it's just, you're a magician. The type of connection we use. There's just so many more problems to face. So the truth is, the more you know, the harder it becomes to make a decision. And that's just life. I mean, Socrates actually said this, that the only true wisdom is in knowing you know nothing. And I think as a man, as a human being in life, it's a question of humility to not walk into any situation thinking you're the smartest person in the room. And I think the greatest sentence that you just finished with was, biology always wins. You can't outsmart it. You can't outcool it. You can't be better than it. So you just have to face the fact that with all the humility in the world, we're just dentists. My wife said that the other day. We're in a lecture somewhere, and you know, we're rock star. Hey man, you're a rock star. Everybody's listening. She's like, but you're just a dentist. You know? Now, I want to talk about something that I think is killing dentistry, and that's how much can you afford? How much money you got? What insurance have you got? Let's see if I can fit your problem into your wallet. Now, this is NYU, one of the greatest institutions in the world. Now, can I ask, how many of you learned how to fit money into a treatment plan? Raise your hands. Mary has 3 cavities. She needs 2 root canal treatments. She needs some bone regeneration, 12 crowns, and she has $500 a month she can pay. Do you learn that here at NYU? So why is that what we're doing every single day around the world? It's everywhere in the world. You're trying to fit a problem into a medical problem into a financial problem. And that's just, we're not trained to do that. So in the course of this 30 minutes, I'll explain that I said I'm done. I had it. I refuse 50% of my patients. But something incredible happened. I stopped having stress. And now for some dentists, the clock is their boss and the only way to make money. How many people here see a patient every 30 minutes? Okay, because I really think that's tough. Now you're going to ask yourself, these failures that we just seen, all that cement around the implant, is anybody questioning the time that the patient spent with that patient? Is anybody questioning that? We're questioning the biology, the mechanics, the treatment options, but is anybody actually questioning how long did that dentist spend with that patient before he even started the treatment? Abraham Lincoln said, give me 6 hours to chop down a tree, I'll spend the first 4 sharpening the axe. Preparation is everything in this game. And for a lot of clinicians, patients are in a production line, and production line dentistry just doesn't work. If you want to do the cool stuff that you've been seeing here today, if you want to have long-term success, volume over quality will never, ever prevail. It's not a formula for success in dentistry. So if you've got doctors on small commissions, doing quick procedures, doing volume over quality, finance-based diagnosis, this is killing dentistry and why I'm seeing so much bad stuff in my practice and why we see so many failures happening. So use your moral code with the license that you have and do good stuff, all right? You've got to learn to say no. I'm not going to do this. I know too much about the science. I know too much about the clinical results, the papers that I've read, the lectures I've attended. If I do what you're asking me, this will fail. But there's $100 on the table. I'm sorry. You've got bills to pay, kids to put through college. You've got your student loans to pay off. And there's $1 grand on the table. Come on, doctor. Just do my 2 front crowns with no posterior function whatsoever. Just these 2 veneers. If you don't do them, I'm going to go to the competition. Oh, man. Take the money, quick fix, 2 front veneers. 3 months later, my veneer's cracked. You're a terrible dentist. I'm suing you. Whose fault is it? And that's why it's important for me to have a team approach, and that's what I'm talking about today. And a team approach is very simple, deciding who does what when. And that's what interdisciplinary dentistry is. Now, not all of you are going to have the privilege of working with the team under the same roof, but I'm sure you've got your colleagues that you can refer to. And remember that time is something that really helps patients choose a treatment. If you can offer excellence fast, that's also something that people like. So I'm going to show you a case, and I really have to thank Team Atlanta just for showing me the way. And that was the biggest decision I ever had, was hiring my the first professional. I mean, I was 27 years old when I hired my perio. I was 28 when I hired my orthodontist, my endodontist. I've been with the same lab for 17 years. You know, we're a family. And nowadays, we pretty much work through Bluetooth. And this is pretty much how we do that. And it was Team Atlanta that actually showed me that sharing your cases, working together, synergies, that always inclusive, and thank you for that because it really has changed my life and my patients' lives too. So here we have a patient who had massive loss of vertical dimension, and I was trained that with cases like this, you can't do full ceramics. So this is the x-ray before we started. Now we're going to need some perio, some endo, some cosmetics, some implants, some prosto, good lab work, and we're going to make sure that occlusion is good. Otherwise, if we don't do all of this, we are going to fail. Now the patient said, doctor, I just want my 4 front teeth. It's my daughter's wedding coming up. Do you notice how patients always come to the clinic 2 weeks before a wedding? You know what I'm saying? So I said, listen, I can't do that if you don't have posterior function. Oh, but I can't afford that. What am I going to do? Take the money that she's offering me to do the top arch and not do the bottom? No. And that's why I lose 50% of my patients. Millions of dollars a year that I could make that I don't, because I know if I don't put those implants in the back, I'm going to fail. So our treatment planning back then, we decided to do some root canal treatments to get the post and cores. We prepped the teeth. We raised the vertical using acrylic, and I'll explain why in a bit. We raised about 15 millimeters, and then after about 4 months with those temps in, making sure her TMJ was good, we then passed to the ceramics, full ceramics. This is IPS Empress. I like to call this no half smiles because there's no such thing as a half smile. Patients always see everything. But we've got that posterior function in. And this is her before and after. Looks like she had plastic surgery. And that's a 2-year follow-up, a 4-year follow-up, and a 12-year follow-up with full ceramic. No chipping, no problems, because we controlled everything from the get-go. And we placed those implants, and luckily we don't have any peri-implantitis around these. Now, of course, I would have probably done things differently. We've got some great work from Vailati in Switzerland. Now, not doing the root canals. I probably wouldn't do that today. But that was 12 years ago, so great things about these courses and these summits and these conferences is that you're always growing and always adapting. So this patient came in and said, I don't like my diastema. Could you close it for me? And he came with 2 other treatment plans that involved direct ceramics, so veneers. And I said, well, how the hell are you going to close that just with veneers? It's not possible. And on top of it, he had an impacted canine. He needed some root canal. And his central, tooth number 9 in the US, had a problem. So again, the team, we sat down. We said, we're going to need some perio, some ortho, some endo, some cosmetics, some process, some lab, and implant. Who does what when? How can we maximize the time this patient comes to the clinic and do as much work in the minimum amount of time? So the first thing to do was the root canal, and that happens in the morning. And then in the afternoon, we expose the canine. I do a little surgery with the piezo, and then we take out that front tooth. We raise an aesthetic buccal flap, as described by Steigman and Homle Wang. We clean that up. I just fill that with BioOS. I put, this is a hyaluronic acid sponge because I had a very thick biotype, so I trusted that nature would regenerate well. We put a membrane, sutured that all up, and then my orthodontist had a Helix traction device. And it took us about, I think, 13 months to pull that canine down very gently into its spot. And again, Maurice, I learned so much from you in pre-surgical orthodontics, using ortho as an integral part of your treatment planning. Now, so many people think of orthodontics as the final treatment. At our clinic, I would say 20% of every single orthodontic treatment is then completed with surgery and cosmetic dentistry. Orthodontics is not the final treatment in most cases, at least in most adult cases in our experience. So we're about 5 months to go on the orthodontics, and this is where treatment planning comes in. Okay, now let's get our implant in so that by the time the patient takes the ortho off, we can put the crown on, saving the patient time, instead of finishing the ortho and then starting the perio, or starting the implant surgery. So we place that implant a little bit more mesially because I asked my orthodontist, where are these teeth going to be? So she kind of tells me, and this is before DSD, before any of that treatment planning. So we put that implant more mesially, and we placed that implant. Didn't do any loading. This is just a composite crown that's attached to the ortho wire, which is also something that we can use. And then what happened, we couldn't explain this. The patient had a traumatic, fell basically and cracked his lateral. On the day, 2 days before, we were about to cement the final work. Now, this guy's a banker. He lives in Africa, has very little time. Not something that I could say, oh, let's now place an implant. So what we did, studying the studies that came out from Team Atlanta, knowing that this pontic, the distance we had from the gingiva to the bone, that we would probably have a good result if we did a bridge. So we just did that, and we cemented that in place. Look at the gingival height. And that's a 7-year follow-up, and you can actually see, because the patient didn't use a mouth guard, who was saying yesterday that all patients should wear a mouth guard after they, Maurice, see the migration happening here? And that's a 7-year follow-up, very stable, but again, interdisciplinary dentistry at its best. Here's another case, more recent. Patient comes in with cosmetic issues, and we sit down, we've got the CBCTs, and we shut our clinic down on Friday morning. So from 8 a.m. to noon, no dentists work. And we all sit in a room, and we put up the cases that we've just communicated to our patients that have been accepted, and okay, what are we going to do? And it really is a team approach. So we figure out who's going to do what when. Now, you can see here we have a cavity, so we're going to have to do some normal dentistry here. We've got some root canal treatments. We're going to have some post and cores. We need a sinus. So we do this for patient understanding. It's just using Keynote. We just superimpose this over the X-ray, and patients really like this because they can understand how much work is going to be entailed. And the truth is that the more your patients understand about your difficulties and how much work you have to do, they become part of the solution, and that's something that is super important. Our first appointment takes about 2 to 3 hours. And then we'll see them again for another 1 to 2 hours where we'll explain what materials we're using, the protocols, everything. Our patients, we like to say at the end of the adventure of rehabilitating their mouths, literally could actually go work in a dental practice. Because it also minimizes problems. When things go wrong, they understand better. And I say, listen, man, this is a partnership. You're not here coming to buy something. You can't buy your smile. This is something we're going to build together. And when they understand that, your patients become your partners and not your enemies, because everything can go wrong in any one of these treatments. So Dr. Cartilage goes in one session, so the patient will sit in for the whole morning. We'll say, take your day off, come in, and we'll sit them down, and they'll spend the whole morning doing endo, and then in the afternoon we'll go straight to the surgery. So the patient comes and spends the whole day with us. They bring a tracksuit. Sometimes they take a little Valium or something like that, and we bring them lunch in between. And they really feel that they're being taken care of. And to get so much work done in one day, this really spreads like wildfire. They're like, man, go to this clinic. They just do everything in one day. So this is much more appealing to your patients than any Facebook page or any website. I've done a lot of promotion in my time. I did TV shows. Nothing has brought me more patients than treating your patients well. Nothing. Just remember that. So go slow. So in this day, we're going to raise a flap. And as explained in the first lecture yesterday, using piezo surgery, we're going to open a little window. And unfortunately here I did have perforation. I learned very much from you yesterday. So thank you for that. I like the idea of using the CBCT to understand where the septum is so I can program that better. I really thought that was clever. And Scott, I want those 3D guides to open the window. That was just genius. So I probably, once I implement that, I'm going to stop having this problem. But we then followed the protocol of perforation. We put collagen membranes in. We put some PRF in there. And then we filled this with BioArt to fill that in, mixed with the PRF. Now, one of the things about this new implant system that I'm using, you also, Dr. Park, yesterday talked about the design, the thread design of this MegaGen implant, is that I'm getting incredible stability where usually I wouldn't. Now, I've got very minimal crestal bone here, and usually I would wait 6 months before I place an implant. But I was getting bolder and bolder with this design over about a 6-month period. I just started seeing things. I was having better stability. So I said, you know what? I hadn't planned placing the implant, but I'm going to. So here we have placing this AnyRidge implant, which has this design. And again, I urge you to study the design. And that's what design is, making things that we already use better, like in chairs, knives. You see it everywhere. Why not in implant dentistry? And of course, here we're going to submerge these implants completely. We're going to use some PRF by my good friend, Dr. Joseph Shukrun. If you follow his work, he's taught me a lot of how to use this and manipulate this technology. So we're going to use some deep sutures here. I like to use what's it called? It's called Resorba. It's a resorbable suture for the deep ones to create a tension-free suture. And then I close it up with nylon. I like to use the 5-0. And on the left side, you can see there, we just did a tissue punch because we had a good quantity of keratinized tissue. But following Howie's lecture yesterday, I think I'm going to stop doing that because the punch in the face thing, I think, kind of freaked me out. So here we have, you can already see how much work has been done. We've got the endo done. We've got the top endos. We've got some post and core done here. And I think we're good to go. So we take a CBCT to see if everything is all right. And after 6 months with PMMA structures in the mouth, we then are ready to place ceramic. And here's the final X-ray. And as you can see, we didn't go for implants everywhere. The distance of bone here, the width of the bone, we wouldn't have had success. The patient wanted something done easy, didn't want to do some surgery there. So again, I'm a big fan of bridges when they work. We all know that they have issues. We all know that they have a certain lifespan. Patient was fully aware of that. But we've got full occlusion in the posterior so we can have that anterior aesthetics. And again, a team approach to giving this patient back her smile. And we like to call it life-changing dentistry because it's not always about doing what's perfect, but it's trying to push the envelope to make sure you're getting as close to what is correct as possible. So here we have another case of, could you just remind me when I have 5 minutes left, thanks? This is quite a complex case. Patient, again, is going to need perio, ortho, endo, cosmetics, prosto, lab, and implant surgery. This patient lives in Africa. So that's a 9-hour flight to come to my clinic. So we had to try and do as much work as possible. Now, ortho was a deterrent, because if she's traveling to Africa every time, I mean, how are we going to do that? But it was the right thing to do. It's not my place to judge if that's going to be expensive or not for the patient. So here we have our digital planning. And we had planned 2 root canals on the centrals, but fortunately for her, we only needed to do 1. The other one we managed to salvage. And then over a 14-month period, we brought those teeth back into place using the Damon system. On the day we removed the device, we did some bleaching, and we decided to prep those teeth as well. And this is the implant phase. Here you can see again a tissue punch technique, how the small hole with this Megagen implant just seems to disappear into the bone. This design is something I've never seen, and I've worked with a lot of systems. And on the bottom, look, as you can see here, we've got a good volume of crest of bone on the buccal. And on the bottom, we're going to do a little split ridge using piezo surgery, using the implants themselves to actually create more width in the crest. So we split that with the piezo using the classic protocol. And then we just we stretch it a little bit, and then we let the implants themselves do the rest, making sure everything's okay. And then once everything is in place, we do the cosmetic dentistry, and we prep those teeth. We decided not to touch any of our other natural teeth, so we're just keeping it simple, just the 2 centrals. There's a lot of tendency sometimes to put veneers on everything else. But in this case, we wanted to keep it simple and try and keep it as natural as possible. So that's the 10th phase. Here we're cementing with the rubber dam. It takes a long time, but it's the right thing to do. And here's the final result. We like to call this invisible dentistry, not cosmetic dentistry. And there's the final smile. And this girl can chew. She's happy. It's not perfect. There's got a little gap at the back right. But all in all, as a team approach, with the patient as part of the team, we got this right. And she's super happy. So I'm going to show you just very quickly my last case. This patient came in, very, very demanding patient. And there's not a lot of light there, but she's missing all of her back teeth. She has a lot of bone loss. And this is kind of a controversial case. So we sat down and we said, okay, we've got 2 options. We can graft everything in the back, do some vertical ridge augmentation. Now, I don't know how to do that. I don't. I can do good bone regeneration, but I can't do that. So we called Juan Alberto Fernandez, whose lecture you'll see today from Ibiza here. And your team was extraordinary. We sent the files. We sent everything. And for those of you that haven't seen his work, he is a magician in bone regeneration. And the patient just didn't accept because she didn't like flying alone, and it meant flying to Ibiza. But thank you for offering to come and do the surgery in my practice. But we actually put everything on the table. And this was the alternative, which is also, most of you know this as the all-in-4. Not something that I'm a big fan of. I would say that in my practice, in implant dentistry for full mouth rehabilitation, only about 20% of my patients would have a pure indication for an all-in-4. I usually like to graft. I like to do 5 or 6 implants. I was talking to Scott yesterday about this as well. We like to place a few more implants. So in implant dentistry, you've got old school, which is pretty much like, let me just fit these implants wherever I can, and, just randomly placing your implants. Or you can be a sniper. And I think nowadays with the technology out there, it's so much more important to use digital technology as being part of your team. Think of it as an extra added team member. This is all done in the cloud. We're working with Christian Coachman's DSD lab here. And it's just phenomenal stuff. They're super hands-on. Francis Coachman, Christian's brother, lives in Madrid, and he does all this. Just upload it to the cloud. And we then got our surgical templates and the 3D printed PMMA structures. This is a teeth-supported fixation pin guide for extra stability. We just hold that into place, extracted those teeth. You can see how stable it is. Now, of course, there's many systems out there. I'm actually testing all systems to make sure that I'm using the best, because I don't just do what people tell me to do. And here we have the implant placement. So this is fully guided. We've actually just placed those through the guide. I don't have enough time to get into that. And as Craig said, we always use an interface. We're never going direct to the head of the implant. So having a good selection of multi-unit abutments. In this system, I have something called an octa, which I'll show you in a bit, which we use on the bottom. And you can see it's pretty accurate. And on the bottom, we just did exactly the same thing. We used PRF as well because we knew that we'd have to do some regeneration. Note that I'm placing the implants subcrestally, and I'm using the mesostructure. Here we've got I think it's a 5 millimeter mesostructure. So once you do the surgery, you're not going to touch the soft tissue again. For patient comfort, it's incredible. And as Craig showed, it really does improve longevity in these cases. And we did immediate provisional prosthesis. Now, these are pure PMMA. I do have some fracturing. I'm not happy with this because every now and again they do fracture. So we had to figure that out. And I'll show you what we did. So every now and again, these things do crack on the cantilevers. And that's why having a metal infrastructure is a lot better. And that's doing at 72 hours. But that requires taking an impression. But here we've got the healing after 3 months. Everything seems to be OK. We did then a quick study where we superimposed the implants to planning to the CBCT. And what we discovered, what we actually had, according to the literature, a larger deviation than what happened in the literature. So I'm not 100% safe with these systems yet. But I know there's room for improvement, as you saw with Scott's amazing lecture yesterday. And then we just did old school zirconia bridge, screw retained. And we finished this case actually last week. And she's pretty happy. And hopefully we'll have some longevity. So just to finish very quickly, this is the kind of case that we had to throw the book at this case. I like to say everything and the kitchen sink. I will be posting this case on XP very soon. And I'll just run through this very, very quickly. We cleaned everything up, placed those implants. And here we used a really cool device. So we've got tissue punch technique through the soft tissue. And here we use the patient's own teeth. It's called the smart dentin grinder. And when we extracted those teeth at the top and we wanted to regenerate the bone, not only did we place implants simultaneously, but we also, we wanted to do immediate loading. So here we have the result of the smart dentine grinder. And you can see all about that outside. We use the PRF. And this is the Versa burrs. These are Versa burrs that are anti-rotational, and they inject bone into the socket. They're great for grafting. They're great for ridge expansion. Very, very clever system here. So we use those as well and place those implants. We're happy with the stability that we had. This is an ATP low-level laser therapy for improved healing. This is the end result. And according to Professor Park, we could actually load these implants on a fully edentulous because we had measurements of over 70 on the ISQ. So we took our impression because I didn't want these things to break. And while we were waiting for the teeth to come, we finished the root canal treatment. And this is the structure which actually has a metal foundation. So we know that this is not going to break. And we also know, according to the studies, that this is actually going to be better for our implant healing. And this is the bun in the oven that we will show on Dental XP very soon. So this is my team. I'm very grateful to all of them. They work very hard so that I can be here on the stage. So just guys, you've got to think, what kind of dentist do you want to be? How do you want to use your skills to change people's lives? Remember to go slow, and thank you very much for having me here today.